Peptic ulcers can cause extreme pain, and they affect millions globally each year. They form when stomach acid erodes tissue, leading to open sores inside the stomach. Peptic ulcers are classified into two main types. Gastric ulcers occur on the inside lining of the stomach. Duodenal ulcers occur on the inside lining of the duodenum, the first part of the small intestine. Lifestyle choices significantly increase risk factors, but prevention and treatment are available. In gastric ulcer, pain usually 30 to 60 minutes after meals. Worsens with food, pain rare at night, usually located in left upper epigastrium. But in duodenal ulcer, pain occur 1.5 to 3 hours after meals, often occurs at night, relieved by food and usually in right epigastrium. Assessment findings are epigastric pain upon palpation. Pain that radiates to the back may indicate perforation is imminent. Bloody emesis, hematemesis, or stools, melena, and weight loss. Causes of peptic ulcers are Helicobacter pylori or H. pylori infection, use of nonsteroidal anti-inflammatory drug, NSAID and corticosteroid use. Also severe stress, excess alcohol ingestion, chronic pulmonary or kidney disease. Zollinger-Ellison syndrome can cause ulcers. Esophagogastroduodenoscopy, EGD, provide definitive diagnosis, and gastric samples are obtained to test for H. pylori infection as well. Medications can interfere with testing for H. pylori and can cause false negatives. Therefore, a complete medication history should be reviewed prior to testing. The medication that affect H. pylori test are bismuth, misoprostol, sucralfate, histamine 2 antagonists. Common medications used to treat peptic ulcers are 1. Antibiotics, eliminate H. pylori infection. 2. Histamine 2 receptor antagonists, ranitidine hydrochloride, famotidine, Pepcid, suppress the secretion of gastric acid by selectively blocking H2 receptors in parietal cells lining the stomach. Treatment of peptic ulcer disease is usually started as an oral dose twice a day until the ulcer is healed, followed by a maintenance dose usually taken once a day at bedtime. Ranitidine and famotidine can be administered IV. In acute situations, ranitidine can be taken with or without food. 3. Proton pump inhibitors, pantoprazole, esomeprazole, reduce gastric acid secretion by irreversibly inhibiting the enzyme that produces gastric acid. Reduce basal and stimulated acid production. While taking PPI, instruct the client not to crush, chew, or break sustained-release capsules, and take PPI once a day prior to eating in the morning. Encourage the client to avoid alcohol and irritating medications, NSAIDs, while taking PPIs. Fourth drug of choice is mucosal protectant, sucralfate, carafate. Give 1 HR before meals and at bedtime. Fifth drug of choice is antacids, aluminum carbonate, magnesium hydroxide, milk of magnesia. Antacids are given 1 to 3 hours after meals to neutralize gastric acid, which occurs with food ingestion and at bedtime. While taking antacids, give 1 hour apart from other medications to avoid reducing the absorption of other medications. Surgery is considered when ulcers do not heal with medication, complications occur, or there's a high risk of perforation or bleeding. Gastrectomy is removal of all or part of the stomach. Can be done laparoscopically or via open surgery. Gastrojejunostomy or Billroth 2-2 procedure. Surgical removal of the lower stomach. The remaining stomach is connected directly to the jejunum. The duodenum is closed off. Vagotomy is another surgical intervention. Surgical cutting of the vagus nerve fibers that stimulate acid production. Highly selective vagotomy targets only branches that influence gastric acid secretion, reduces acid, but may slow gastric emptying. Pyloroplasty is another choice of surgery. Surgical enlargement of the pyloric opening between stomach and duodenum. Facilitates faster gastric emptying, often done with vagotomy to offset slowed digestion. Post-operative care are monitor incision for evidence of infection. Place the client in a semi-Fowler's position to facilitate lung expansion. Monitor nasogastric tube drainage. Scant blood may be seen in first 12 or in 12th into 24 hour. Notify the provider before repositioning or irrigating the nasogastric tube. It may lead to disruption of sutures. Monitor for complications like dumping syndrome, nutritional deficiencies like B12 deficiency, pernicious anemia, infection, bleeding, delayed gastric emptying. Keep patient NPO initially, then advance diet gradually. Monitor bowel sounds, pain, vitals. Educate patient on eating small, frequent meals, avoiding high-sugar foods which prevent dumping syndrome, lifelong B12 injections, needed after total gastrectomy. Thank you.